Welcome, everybody. This is probably the best attended in-person ATI rounds in the last 10 years, I'd say. So thank you, everybody, for coming. There's lots of different groups here: cardiac surgery, anesthesia, lots of people from the CVIC, the CVORs, lung transplant, obviously. So thank you guys very much for coming for, I think, quite an important event. I'll just start with a land acknowledgement. We acknowledge the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. And then a thank you to Paladin, Astellas, and AstraZeneca for their ongoing support for the ATI seminar series. So then I'll just introduce you guys to Dr. Konrad Höetzenecker. Hopefully you guys have met him before or seen him before. Probably many of you have read his work before, but he's an MD PhD and an appointed professor for lung transplantation and the director of the Vienna Lung Transplant Program at the Medical University of Vienna. Besides lung transplantation, he also specializes in airway surgery and extended thoracic procedures and has published in many of those areas. Dr. Höetzenecker has authored numerous peer-reviewed articles and is well respected in our big international society, the ISHLT, and is an editorial board member of the Journal of Thoracic and Cardiovascular Surgery and the Journal of Heart-Lung Transplantation, which is our big lung transplant journal. He's been awarded several prizes and grants, including the Graham Memorial Traveling Fellowship for the American Association of Thoracic Surgery. And so I've had a chance to see Konrad speak on multiple occasions and on this topic, and last at ISHLT, and we got talking about, the relationship to how he's doing things and how we do things here. So I invited him for a virtual lecture, and he one-upped me immediately and said, "I'd love to come to Edmonton." And I said, "Okay, that's amazing." So we set this all up, and I want to thank you very much. And if you guys can join me in thanking Dr. Höetzenecker for joining us, we can get going.
So good morning, everybody. Thank you very much for this very nice introduction, and thanks for having me here. Can you hear me? Okay, good. So Kieran asked me to talk about lung transplantation for PH and post-op management, which is something we have been over the years become very interested in Vienna. How can I? Oh, I cannot advance my slides. Oh, I can't. It doesn't work. Oh. Choosing the right posture. Yeah. That's it. Any questions?
Thanks for coming. It's crazy. Okay.
Oh, now. Okay.
Okay, you're up.
Sure. Thanks very much. So here are my disclosures. I'm a consultant for Medtronic for their double lumen cannulas, which are not relevant for this presentation because you can use them for PH, as I will show you. And all patients have given their permission to show their photographs for scientific talks. Hey, hi. So this talk will cover the indication and timing of lung transplant for PH, the choice of procedure, the bridging options, and then the post-op management, which is probably the largest part of this talk. So I'd like to start by saying that lung transplantation for PH is actually rare. I work in a transplant center. We're doing 120 years, a year, sorry. And if you look at the pie chart on the right side, only 8.6% of our recipients are actually PH patients, despite the fact that we are a referring center for the care of primary arterial hypertension. And if you look at ISHLT registry data, in the latest period, 2010 to 2018, only 2.8% of transplant recipients were PH patients. So that's a rare patient population. In regard to published evidence, we don't know a lot. So most evidence is just retrospective, single center stuff. when is the right time to transplant a patient? These are the general rules based on a consensus statement of the ICHLT. You know, we can transplant any end-stage lung disease. Most of those are chronic. More recently, we've started to transplant acute respiratory distress syndrome patients after they have failed their medical management. And for most patients, that lung transplant remains the ultimate treatment option, as we know. And so we don't want to do this too early. Also, we don't want to do this too late because we're trading off one medical challenge for another. But if successful, of course, transplantation offers an excellent life quality. This too late and too early way, as you can see on the right side, that's especially important for PH patients, as I will show you later. In Europe, we follow the regulations, or sorry, the rules that were published by Nazareno Gallet and his group. These guidelines are still valid. They have been updated. PH physicians really try to understand what is the risk of a patient when they first present to their clinics. And there are different parameters you can actually look at, whether there are clinical signs of right heart failure, progression of symptoms, the functional class WHO 6-minute walk test. And you can, by just grading patients into these categories, you can get a good understanding about their risk profile. And that's important because this determines the further course of their treatment. If patients upon the presentation are in lower intermediate risk group, you start them with combination oral therapy. When they're in the high risk group, you immediately start them on a prostacyclin IV or subcutaneous pump. And then you reassess them 3 to 6 months later. If they don't respond to the therapy, you should consider referring those patients immediately to the transplant center. And this is important. So the transplantation comes into the treatment algorithm quite early. So in case of an inadequate clinical response to the primary therapy, you should see as a transplant surgeon, you should see these patients. And this has changed over the time. In the guidelines 2009, you can see the transplantation was just down in the left corner. And over the years, it has moved up, and now it's in the middle of the treatment algorithm of PH patients. Why is this? Because we don't want to see patients for transplantation when they are already in right heart failure. As you can imagine, then transplantation becomes very challenging, and the so-called reverse cardiac remodeling during the post-op phase is really difficult. So we really want to see a guy like on the right-hand side who is still in a good clinical condition and a good muscular condition for transplant. What happens if you get your referrals too late? You have bad post-op outcome, resulting that your referring physicians would probably either not send you another patient or send you the next patient even later, because he should say, you know, let's just exploit all other treatment options because outcomes of lung transplantation are not good. And then there are additional factors you need to consider in PH patients. The subtype of disease. If you have a PVOD, which is a venous occlusive disease, then the treatment options are very limited, and you should immediately list those patients upon diagnosis. And this has become a more or less consensus within the European community within the last couple of years. And then you have to look at the expected waiting time of your individual center. And that's important. This is the waiting time of Eurotransplant. Austria is part of Eurotransplant, and you can see that the wait time range is between 6 months, depending where you work, and 2 years. 2 years is in Germany, 6 months is in Austria. So if you have a good donor availability, you can probably accept a later referral than if you have a bad donor availability in your country, then you need to see those patients early. What about bridging? Now we bridge patients, deteriorating ILD patients, COPD patients. If they get, too sick, we just put them on ECMO and stabilize them, get their transplanted. Is this also true for PH? And try to advance this. Yeah. Actually, it's more complicated because unlike parenchymal lung diseases where you just have patients in respiratory failure, patients who deteriorate with an underlying PH diagnosis, they go into hemodynamic failure. So bridging patients with hemodynamic failure is more complex, as cardiac surgeons know this better than me. So usually we bridge patients to the lung transplantation with a VV ECMO device, which has evolved like the single lumen cannula, or so the single site double lumen cannula, has evolved as the standard for those patients. You cannot use these for PH because you have a hemodynamic problem. So either you use VA ECMO or other devices, depending whether your patients are in right ventricular failure or in biventricular failure. And bridging PH patients is unfortunately feels like driving through one of those dangerous Himalayan roads. So you never know what do you expect around the corner and whether you make it out of this situation. The standard of care in most lung transplant centers is a FEM-FEM VA ECMO because it's relatively easy to insert. You can actually do this on the ICU at the bedside in local anesthesia, which is important because you don't want to put patients under general anesthesia when they're already in right heart failure. Probably many of you have seen those patients, and they are in a situation where you need to resuscitate them pretty fast. The downside is difficult mobilization. Of course, if you have a VA ECMO in the groin, it's more difficult to walk the patients. North-South syndrome, not so important. I will show a slide later. And the flow is limited to the vessels of the groin. Usually you can't go higher than 3.5 liters per minute. So the North-South syndrome of watershed phenomenon is that you cannot oxygenate through a peripheral VA ECMO because the left ventricular ejection fraction kind of works against the ECMO flow. So the oxygenated blood of the ECMO just reaches the left hand, but the brain oxygenation, the right hand, is usually contributed to what the lung actually uses or what the lung does. This is not that relevant in PH patients because their lung usually have a still preserved oxygenation capacity. So alternatives, you can either do a subclavian cannulation, which makes the North-South syndrome less likely. Mobilization is much better. This has been in the field of lung transplantation promoted by Matt Paqueta. And he kind of termed this mode as the ECMO sports mode for PH patients. So you can actually let them make sports. The problem is that the rate of embolic complication is higher than when you do a peripheral a FEM-FEM VA ECMO configuration and have this hyperperfusion problem of the right arm. And if you have embolic complication, your patient has a stroke. And of course, it requires an operation room and general anesthesia to insert it. This is a typical picture of microembolism. I'm sure you have seen this. So we don't use subclavian cannulation in our bridging patients in Vienna at the moment. Another interesting option has been proposed by the UCLA cardiac surgeons through the fusion. Cardiac surgeons are used to access the ascending aorta through a right-sided third intercostal mini thoracotomy. You can actually just cannulate centrally with a tunnel and get the same kind of support as you have when you cannulate the subclavian artery. It's surgically a little more challenging. The risk for embolism is actually the same as in the cannulation of the subclavia. ambulation is possible, and it's probably the most physiological support you can get in PH patients. And then there is the PALA novolung, and I'm pretty sure the Toronto people have shown you this before. This has been developed by the Toronto surgeons. The idea is that you introduce a septostomy-like shunt. So you put in a draining cannula in the PA, and you return the blood to the left atrium, bypass the lung circulation, and between those cannula, you add an oxygenator, so it's a pumpless way to bridge patients, and it's like an overflow ventil you use to bypass the severely damaged lung. The problem is you need a sternotomy for this, and you need a VA ECMO for insertion because you manipulate on the heart in a patient who has a failing heart as by definition. So you need to stabilize the patient first, then do the sternotomy, then insert the PAL novolung, then remove the ECMO, close up the sternum. So it's a complicated way to bridge patients. So we have adapted this approach in Vienna. We have done 2 patients where we used, we did not use a sternotomy, but rather a left-sided thoracotomy, which we can use for the later clamshell in our transplant. Just a big advantage is that you don't completely destroy your sternum after transplant. So the draining cannula goes into the left PA and the returning cannula in the left upper lobe vein. And by this, you can see this picture here. It's like 2 cannulas, the ECMO cannulation here. This is the central PAL novolung, and this is the patient afterwards awake and exercising. Yeah, you can effectively reduce your PA pressures and unload the right ventricle. So patients in right ventricular failure, and this is only bridging options for patients where the left ventricle still have a preserved function, can actually stabilize them and keep them going for a couple of days, weeks to get their transplantation. The truth is, and I think that's very important when you go to meetings and you listen to people saying, it's like, this is the right way to bridge patient. No one really knows. We have bridged 11 PH patients in Vienna out of the 200 lung transplants for PH we performed. 8 were FEM-FEM VA ECMO, 2 PALA novolung, 1 VAV ECMO, median bridging time 4 days. We bridged 100% of those patients successfully to the transplant. 80% survived 1 year. Why is this important? Because this is ISHL UNOS data actually published 3 years ago, almost 2.5 years ago. You can see that within the huge UNOS database, only 97 PH patients were bridged to the transplantation, and 50% died during bridging. Okay, so the best option is not to need a bridging and get your patients referred early. And this is the conclusion for the part 1 of this talk. So refer your patients early, see them early. Unlike COPD and ILD patients, a little too early is probably acceptable, and you need, if you can, avoid the situation or a situation where you need ECLS devices to stabilize your patients, because then you're in a difficult situation. So let's transplant, but which procedure? And there has been a lot of discussion during the past. Should we do heart lungs? Should we do lungs? Should we do single lungs? What can be done? The discussion is based on historic historic data, probably, that at the beginning of lung transplantation beginning of transplantation for PH, heart lung were the standard of care procedure for these patients. And this is based on the Stanford experience of Shumway and Wrights. And at the beginning, it was considered that the heart is just too sick to be able to recover in patients with a severe pulmonary arterial hypertension. And then in the 1990s and 2000s, lung transplant centers started to experiment and just putting in double lung transplants in PH patients. And they found that with the right expertise in post-op management, you can actually get away with just replacing the lungs and the heart, despite the fact that they are severely impaired, severely dysfunctional. Hearts recover. because at the end of the day, heart is just a muscle and it can adapt to different situations, right? Much easier to understand than lungs. Good. So I'm a thoracic surgeon, so I don't know anything about about heart. Sorry. This is the historic data behind this concept. You can see that Wash University and the European experience in Paris can see that the survival curves are exactly the same. So from based on this experience, most transplant centers have completely moved away from offering heart-lung transplants to PH patients, and double lung transplantation has become the standard of care for PH. And this is what we do nowadays for PH, as I told you, bilateral lung transplantation for PH with simple cardiac defects like an ASD or like a PA trunk aneurysm, and I've prepared a case to show you afterwards. Or we've had a couple of cases where a pulmonary vein was draining to the SVC, and you can just repair this and do a double lung transplantation thereafter. If you have a PH together with complex cardiac defects, you need to replace heart and lungs, but those patients have become extremely rare because usually they are picked out in their early childhood. The cardiac defect is repaired. So what about the grown-up congenital heart disease patients? And we see more and more these days where their heart was not sufficiently repaired, and patients will develop a secondary like fixed pulmonary hypertension. And so deciding when the right time, or if there is if these are candidates for lung transplantation, is very difficult. A lot of discussion within the field. So there's a big question mark whether you should actually proceed with a lung transplantation in those patients. What about single lung transplant? And every now and then there is a case report suggesting that you can actually get away with just replacing one lung. We don't do this. I don't think that any big lung transplant center would consider lung transplantation in PH. The problem is that if you only replace one lung, you have a severe volume overflow of this single lung transplanted graft, because this has a normalized PVR, whereas the native lung is still damaged. You have a situation where in the perioperative phase, you have hemodynamic instability, severe primary graft dysfunction, and then later, and I think that's the biggest or the most important argument, that the VQ match results in early clot. So you should not do a single lung transplantation for PH. So what is this cardiac remodeling, or why are PH patients so different than COPD and ILD in their perioperative treatment? And this is probably like the best evidence of cardiac remodeling. Just look at the X-rays, and all these PH patients look the same. They have a huge distended heart before transplant. After transplant, when they have stabilized, the X-ray look completely normal. And there are three dimensions of early post-op challenges in PH patients. And I'd like to look at the right ventricle, the left ventricle, and the graft itself. And then based on this, decide what is the optimal strategy to bring patients through this perioperative problem. So the right ventricle, and this is the good news, we don't really care about the right ventricle. We are very worried about the right ventricle before the transplantation, because it can fail. It cannot overcome this high PVR. But immediately after transplantation, once you have exchanged the lungs, the PVR, of course, drops to normal values, and the right ventricle is super happy and just pumps away everything you offer him or her. So you can actually see, you can actually measure this just looking at the RV ejection fraction. So all these people, all these patients have a completely normalized right ventricular ejection fraction after transplantation. We're very worried about the left ventricle, because the left ventricle is usually chronically untrained because it's not used to normal filling pressure. So what happens after the transplantation is you have a super happy right ventricle, just pumps away all the blood through the lungs. The lungs the blood just continue to the left ventricle, and they have a high, like a preload to the left ventricle. And so the left ventricle sometimes cannot handle this and is prone to fail. And the strategies we use to avoid this is offer inotropic medication prophylactically to the left ventricle, meaning that we have all those patients on 5 gamma dopotrex or levosimendan. I don't know whether it's available here, but if we don't have them on dopotrex, we just have them on levosimendan once a week. The second important point here is to reduce the transpulmonary blood flow to unload the left ventricle. And you can do this by fluid restriction, of course, so keep your PAH patients as dry as possible, avoid volume challenges, and then Kieran asked me to talk about the prophylactic post-op VA ECMO. This is another important piece of in the puzzle of reducing transpulmonary blood flow. And then the third dimension is that the graft itself. And it's important to understand that whatever you do, if you do EVLP, if you do 10-degree storage, so any organ you implant has a certain amount of endothelial leakage or endothelial damage due to inflammation processes going on. So, and this endothelial leakage is important to keep in mind because this automatically leads to a certain degree of edema. Sometimes you don't see this or very often you don't see this in the X-ray. You don't see this in your ventilation, but there is a leakage. And if you increase your blood flow through the pulmonary vasculature, you will increase automatically the formation of edema. If you decrease the blood flow, you will decrease the edema. So the device that can actually reduce transpulmonary flow most effectively is VA ECMO. You just take away or bypass the small circulation. If you increase your ECMO blood flow, you will automatically decrease your pulmonary perfusion, as you know. So strategies to support the graft is, again, to reduce transpulmonary blood flow by fluid restriction and by post-op prolonged VA ECMO. And then for the surgeons, I think it's important to avoid implantation of small immature vascular beds. So no lobar transplantation in PAH patients. That's a risk factor, and no pediatric donors. If you have seen like the PA of a 15-year-old patient and compare this to the PA of a 70 or 80-year-old donor, you immediately understand the differences in the vessels, and that this has to have an impact on the function. So post-op prophylactic ECMO, and this is how we have, how we do this in Vienna at the moment. We always use this in a fem-fem veno-arterial way. We implant 15 to 17 French femoral arterial cannulas, so quite small, and then a draining cannula of 17 to 19. The cardiac surgeons would go much higher, but we don't need to replace the heart function. We just need to kind of support and bypass fluid from the small circulation. And then we decided to always, despite these small vessels, put in a leg cannula just to confirm that the leg kind of keeps perfused. The anticoagulation strategy is by standard a low molecular weight heparin, subcute twice daily, and we guide with anti-10A. This is our institutional standard. So post-op VA ECMO for PAH patients stays in our patients for a mean of 2 to 3 days. So this is really just to kind of support the patients for a couple of days to stabilize them, and then the ECMO goes away. And with this outcome, and this is a publications back in 2018 by one of our transplant surgeons who looked at the outcome if you don't have an ECMO strategy, a post-op prolonged ECMO strategy, and compared it to the post-op prolonged ECMO strategy patients. And you can see that the early mortality can be overcome by just prolonging the ECMO in a prophylactic way. Let's try to advance here. And then there is, there is a kind of duality between Vienna and Hanover in Europe. So Hanover has a similar approach. What they actually do, they extubate their patient and keep them on ECMO even a longer period of time. So in Vienna, we would just explant the ECMO, then wean the patient from the respirator, extubate. In Hanover, they would do it the other way around. So they have a kind of a wake ECMO concept in their PH patients. I think both approaches are valid. If you look at survival, exactly the same. So what happens if I told you that negative balance is important in PH patients to avoid volume overload towards the left ventricle? So what happens if you can't achieve a negative balance? So what we usually do is we push Lasix, quite high dosages, immediately after the transplantation. If the patient's kidney starts to reduce the function, we immediately go in and implement a hemodiafiltration device. This has been published by Alberto Benazzo, one of our surgeons, I think 2 years ago, and nicely shows that we don't wait until we see, it doesn't show here, I'm sorry. We don't wait until we see that the kidney actually fails with a glomerular filtration rate. We just look at the balances, and those kidneys are still producing urine. We just start hemodiafiltration for balancing reasons. And if you look at the survival curves, they don't, so they overlap. Half of our PH patients were on hemodiafiltration post-op. By definition, they are in kidney failure, right? But we don't see it. We just shut down the kidney. We don't see it this way. We just shut down the kidney to kind of recover the lungs. So it's lung before kidney. And the kidneys in the long term, they always recover. If we look at glomerular filtration rate down the road, 9 months, 12 months, 24 months after the transplantation, has no long-term impact. The exception of the rule, and unfortunately there's always an exception, if you have patients like this, and about 5% of the PH patients, they don't have a distended right ventricle. They have an extremely hypertrophic right ventricle with a RV outflow obstruction. So you need to capture this before the transplantation. And in these patients, you should avoid to kind of squeeze them out. And you actually have to increase your circulatory volume at some point of time to avoid that they get in cardiac failure. So recent survival outcomes of lung transplantation for PH. We can now say that we have a 5-year survival rate of 65 to 75%, which is still a little lower than survival outcomes of ILD and COPD patients. Again, this is a pretty good outcome we are at the moment. Again, is survival a good outcome measure? Probably not. We look at quality of life, which is much more important. It's not published very often, but I think we should really concentrate on how people live than that they just survive a transplantation. We did this a couple of years ago, looking at activities patients could do before the transplant and after the transplantation. And I think that's a very good argument against those newly developed drugs where your 6-minute walk test increases by 5.2 meters. We don't really look at 5.2 meters in our transplant recipients. What we want them to do is we want them to climb mountains, and some of you might know this. We reached the peak of the Kilimanjaro, I think maybe 5-6 years ago, with a couple of transplant recipients. And we don't want to have like 200 6-minute walk tests, 200 meters of 6-minute walk tests. We want them to have it's like 5,000 meters height. And I think that's the end. So that's just a summary that lung transplantation provides excellent outcomes in experienced centers. 5-year survival reaches 75%. Early selection of possible candidates is important, and you have to refer your patients as early as possible. And I think I don't need to remind everybody that it's not the surgeons, it's not anesthesia, it's not the ICU stuff, it's all together, especially in these very complex patients. We usually discuss these patients together at the bedside and decide. And so that's our team in Vienna, and I'm very proud to be a part of this team.